Okay, there we go. Now we're recording, everybody. Welcome to the fourth learning session for our full-scale hypertension initiative. It's pretty crazy looking back on where we started like a year and a half ago to how far we have come now. Really want to big shout out to all of you participants and everybody who has put in so much work to this initiative to make it successful. First, I'm going to ask if you can turn on your cameras if possible, and your mics should be muted. Here is a quick look at our agenda today. We've had some last minute additions and a couple speakers dropped out at the last minute. So our leadership team worked really hard yesterday to pull some extra things together, so we didn't end up with only like an hour and a half of a learning session. So, but it's going to be a wonderful session still. We've got great discussions planned to have, so be ready to come off mute and share your thoughts as we get to those points. First up, we have Missy Hotchkins. She joined us last year for the pilot. She shared her story. She has an incredible story of one of her child's births, and so I don't want to give anything else away. So Missy, I'll let you come off mute. I will stop sharing so we can see your beautiful face, and I will let you tell us your story.
Okay, thanks, Morgan. I am Missy Hotchkin Robinson. I am 39 years old. I was born in Yankton, South Dakota, Sioux Falls raised, Washington Warrior, Augustana Viking. Went to school for business. I underwrite mortgage at Wells Fargo. Been there 16 years this month. Was married in October of 2012, so this year will be 10 years, another big milestone. We've got two children. The first one was born January 30th, 2014, and the second was born September 30th, 2015. So they're 18 months apart. Just a little backstory, excuse me. Our first one, I was 4 months pregnant when my grandfather passed away, and we had a very close relationship. So I ended up delivering him premature. He was about 6 weeks early, 4 pounds, 6 ounces. So we spent 22 days in the NICU. There was no medical issues with me, no medical issues with him. He just basically needed to gain weight. So that was good. But basically that led into the next amazing birth story. So Olivia, she will actually be 7 next month, which is incredible how fast the time has gone. But anyway, when we were pregnant with her, they gave me progesterone shots to ensure that she wouldn't be preterm. And so she was due September 26th, which is pretty significant date because, as I mentioned, I was 4 months pregnant with Corvin when my grandfather passed away. And her due date was actually 2 years to the date of his passing. He passed away on September 26th, and that was also when she was due. So pretty significant there. She was overdue anyway. So the evening of September 29th, we checked into the hospital to get ready to be induced in the morning. And probably about 6 o'clock that morning, I got up to use the restroom for the last time before they gave me or right after they gave me an epidural, or right before. And excuse me, I just kind of felt a little bit nauseous and felt like I needed to call my mom. Like I just felt an inclination that she needed to get up there. I laid back down in the bed and they put the probes back on my belly, and they couldn't find my baby's heart rate at first. And once they did, it was at 40, and where it had prior to me getting up to the bathroom, it was at about 140s. So obviously that was alarming. So then they called in a few other nurses and stuck a probe in to her head and verified that it was 40. So basically from there, it was really quick. Everybody kind of came rushing in. Had my husband sign some paperwork, to which he said, well, I can't sign for an emergency C-section. They said, well, there's really no option at this point. We've got an emergency here. So they whisked me off to the operating room. I vividly remember, because I had just bought a new sports bra from a boutique, and they were going to cut it off. And I said, no, there's no wires in it. There's no need to cut it off. And I don't know why I remember that, but it was just kind of one of the things that I did remember. And then next thing they said is count to 3. And I believe they put a mask over my face, and I didn't even get to 3. From there, Dr. Ashley Briggs delivered my baby C-section within minutes, and she came out perfectly fine, crying. So that was good. And then she was, I believe she was ending her 24-hour shift, so she had to wrap up for the day. So she got me all stitched up and ready for recovery, and then I woke up and my parents were in the room, and I remember asking, who's all here? And I was kind of in and out of consciousness per se. And they said, everyone's here, meaning like my grandma, my aunts, my siblings. And I don't know if that's what kind of made me say, okay, not really sure what's going on here, but keep going. And from there, Dr. Hermanson took over, and she was doing a balloon procedure because my uterus wouldn't contract. So that went on for, I don't know how long, but basically they came to the conclusion that, then I started hemorrhaging and I went into DIC, had to have 13 units of blood transfusions and plasma. Keep in mind, a typical adult, according to the American Red Cross, has about 10 units of blood in their body. So basically depleted all my blood and had to get a lot of blood transfusions. So basically they couldn't get the bleeding to stop after several attempts. And they said, we need to go down for an emergency hysterectomy to try to get this bleeding to stop. And then that's where my husband said, well, I can't authorize that. She's going to be upset. What if she wants to have more children? And they basically said, there's unfortunately going to be no children either way, because either, she's going to die, or we've got to take her uterus to try and stop this bleeding, or she'll bleed to death. So he signed the paperwork. And as they were wheeling me down the hall, down to the surgical tower, I was kind of in and out of consciousness, and my husband was walking beside the bed, and I said to him, or he showed me a picture of Olivia, and I said, can you zoom in? I wanted to see her closer. So he thought in his mind, well, she's fine. She's coherent. She's asking me to zoom in on a picture of our baby. And so he didn't really realize the severity of what was going on at that time. So then the emergency hysterectomy was performed, and that was probably about noon maybe. And I woke up about 5 o'clock that night in the intensive care unit. I was intubated, and I just remember waking up, and my family was in the room, and I was so thirsty, and I couldn't speak because there was a tube in my throat, but I didn't realize that. I couldn't get the words out. Give me a drink, give me a drink. I was so thirsty, and everybody's kind of looking at me like, what? And there was a sink in the room, so I pointed at the sink and drink. I'm so thirsty. So that was another thing that really stood out in my mind of that day. But fast forward, basically, we delivered on a Wednesday morning at 6:56 a.m. And it was, the amniotic fluid embolism is a very rare complication, oftentimes fatal, that can affect the mom and the baby. It's not really well understood because it's again a rare occasion. So they kind of had an idea of what had happened, although there wasn't any evidence. So fast forward to that Friday morning, the nurse is getting ready to take out I had a port and directly into my heart for all the blood transfusions. And Dr. Sierra comes in, and they're conversating, and the nurse asked him if she could take out the port that goes directly to my heart so I could take a shower. And his eyes lit up, and she kind of had her hand like ready to remove the tape, and he kind of swatted at her hand and said, "She still has a port to her heart." He goes, "I don't know what I need to do, but I know I need to draw some blood." Because basically in the cavity of my heart was, the last remaining blood that was originally mine. So he drew the blood, sent it to lab, and then Friday, so over 2 days after birth, it was confirmed that I had amniotic fluid in my heart. So they diagnosed it as an amniotic fluid embolism, which is basically, it's like an allergic-like response to the amniotic fluid in my bloodstream. And that can cause two different things, basically, heart failure, lung failure, and then also DIC, which I don't believe I experienced the heart and lung failure, although some resuscitative measures were taken. But I definitely was in DIC, which is why they had to remove my my uterus emergently. So basically, just a few facts about that. Amniotic fluid embolism, it's rare and leading cause of maternal death globally. About 1 in 40,000 in the United States, it happens. So to put that in perspective, approximately 4 million deliveries in the United States, approximately 100 women suffer an amniotic fluid embolism. Most of them are often fatal of the mother and or the baby. Basically, the percentages of survival can vary greatly because it's, typically their autopsy in a body to figure out what happened. So the research really isn't quite there because it's, pretty rare to survive, but the greatest chance to survive is to be at a hospital with the ability to provide rapid and aggressive treatment, as well as increasing awareness in the medical community. So that's just a little bit about the amniotic fluid embolism. But basically, the experience was extremely eye-opening and life-changing for myself and my family, in that the compassion and the humanity that we experienced with all the physicians who played a part, as well as all the nursing, the techs, all of the labor and delivery staff in general. We have never experienced anything like that in our lives, but it was kind of a blessing in disguise, in that, we just, we travel a lot more. We enjoy the simpler things in life, and are extremely, extremely grateful for everyone who played a part in that day. Every single person who assisted that day was in the right place at the right time. If Dr. Briggs would have clocked out 5 minutes before she did, this could have had a completely different outcome. Everyone was there for a reason, and I believe that is the only reason that we are both still here today. I do keep in contact with quite a few people from that day. I actually had to stay my daughter got released from the hospital before I did, just because I wanted to make sure that I was okay physically, but more so mentally, because it was a lot of unexpected occurrences that happened there. And almost 7 years later, I've definitely got a clean bill of health, and I have had a clean bill of health, but I still question sometimes, like, why did this happen? Why did this happen to me? But on the other side, extremely grateful for the care that we received. And if it wasn't for the physicians and the nurses' rapid and aggressive response, again, it could have been a very, very different outcome. But I just remember in the days following, it was obviously very scary and dark time for me, especially. But Dr. Sierra, he checked in every day. He was traveling for work out of town, and he called at least twice a day to make sure that I was okay. Dr. Briggs, she actually handmade me a beautiful Native American bracelet. And as you can see, right in the center is a cross, which she stated that signifies that our paths had crossed. Dr. Hermanson was there every day to visit, as well as my primary care physician, Dr. Jennifer Klein, who has been a significant part of my life for most of my life. And we have grown quite a bit stronger bond, especially since this has happened. Pre-COVID, we used to, my grandma, my mom, my aunt, and Olivia used to come up to all doctors' offices and the labor and delivery floor and bring either cupcakes or cookies just to celebrate her birthday and to celebrate them and let them know how important they are and what a crucial role they play each and every day, and that their work does not go unnoticed or unappreciated. And without them, again, we'd probably be in a different place right now. So pretty amazing story there, very scary, but it turned out very well because our medical team knew maybe not exactly what to do because they didn't know what they were dealing with at that time, but their quick response and incredible knowledge got them through, even considering, I had 15, 20 family members there. I mean, could you imagine how stressful that would have been speaking to them, not really knowing if I was going to make it or exactly what was going on at that time. So very professional, very compassionate, and just human. And that is what I appreciate the most out of them, is that I really felt like they genuinely cared about my family. And again, based on the relationships we still have to this day, that's evident. So life-changing experience, but we are super grateful for saving mine and Olivia's life. She will be in first grade. So just want to share a picture of her. This is her kindergarten picture. She is alive and well. She was a 4 out of 4 in all areas in kindergarten, which is exceeding, the standards. She loves to dance, very bright, a little sassy, naturally, doing very well. So Morgan does have a link to share. Sanford actually did a video on us when a couple months after she was born. So if you want to see some pictures of when she was a baby, she sure was a beautiful one. And then also there is a link for the write-up in the Sioux Falls Woman magazine, because it was such an amazing story with a great outcome because of our medical team and God, of course. Oh, one last thing. I do got to share the silver lining in this one. I don't typically share it because some people kind of think, oh, that's weird. But I mentioned my grandfather. He passed when I was 4 months pregnant with Corbin. And then Olivia was due on his, on 2 years after he passed away. So as I was going through this amniotic fluid embolism, kind of in and out of consciousness, and they were doing the balloon thing. I remember it was very cold. And I don't know if this was a dream or a hallucination or if it was real. I pray to God that it was real, but I remember looking up and I saw my grandfather and he pushed me back down is what I recall. Again, I don't know if that's divine intervention or what, but it was definitely the silver lining for me. So thank you for listening and hope you all have a great day.
Thank you, Missy. Like every time I hear your story, I just get chills and I cry, and it's just so powerful. So thank you for opening up your heart and being vulnerable and sharing your story with us. I absolutely love that you go and take cupcakes to the like labor and delivery floor and help remind everybody. I think in a hospital, you see so many people come and go that it's easy just to get stuck in the flow of things, but to take a minute and remember those great successes, and everybody leaves and goes on to live some incredible lives after their time in the hospital. So thank you, Missy.
Absolutely. Yep. And everyone played a part in that, and we are grateful for them every day. Knowledge is key, for sure.
Wonderful. Thank you, Missy. You have a wonderful day. Thanks for being with us this morning.
Thanks. You too.
Bye.
Bye.
Okay, so I hope you all enjoyed Missy's story. I think she is such a wonderful advocate and patient to share her story and help us remind us, that they're important and every patient matters. I am going to get my screen back up here. I just want to share a couple data trends that came in. If you haven't sent in your report, please send it in, because we didn't have as many people send in their reports this time as last time. So we can kind of see a little drop in our numbers. But this graph shows the number of facilities that turned in their reports that reported an increase in trends in the different areas that we're following. Part of the drop off is because of numbers, but also as I was going through all of the reports, many of you have reported no change, which means you are sustaining your gains from when you re-reported in May. And so that's good. You'll see it in our next slide here. We have more and more people teams meeting our goals, which is awesome because we set our goals at 100% and made it really hard to achieve those goals. But a lot of your teams have done it. So big round of applause and shout out to those teams. And if you haven't sent it in, here's your sign, send it in, and I can update these numbers as I get them. But this is pretty exciting stuff that we can see our improvements that we've made. So next up, we are gonna hear from Dr. Tobias. I wanna give a quick, just let everybody know how awesome our team is. Last minute, we had 2 speakers drop out and not be able to do a talk during our learning session today. And I was talking with Dr. Van Eerden and trying to figure out, because he was one of our other speakers, and he's, asked Dr. Tobias, she's been doing some great advocating work. I texted her last night and she was like, yeah, sure, I'll do it. So Anna, thank you for being willing to come in here last minute and talk to us. Do you have slides that you want to share, or do you just want it to be on your face so we can all see?
Nope, I do have a couple slides if you
yep, I will stop sharing.
Let me.
And okay. There you go. You should be good.
Okay.
So thank you. Oh, here I have your little intro too. If
oh, sure.
Want me to? Okay. Where did? let me get this out. Okay, so Dr. Tobias graduated from UND School of Medicine in 2010 and completed her OBGYN residency training in Grand Rapids, Michigan, and maternal fetal medicine fellowship at the University of Tennessee in Memphis. She's been practicing as an MFM at Sanford Health Bismarck since July of 2017, and she's also on our leadership team and willing to save the day. So I will let you take on over.
Okay, can everyone hear and see the slides? Okay, good. So I'm just going to talk a little bit about how the overturning of the federal protections on abortion are going to affect the states. And I apologize, I don't have anything on South Dakota, but I can tell you the law in South Dakota is even worse than what we have in North Dakota when our trigger law goes into effect. So I just want to start out by saying I know there's differing opinions on abortion, and that's okay. But I want to point out that all of the national medical organizations like ACOG, Society for Maternal Fetal Medicine, the American Medical Association, all have come out with very strong statements saying that the overturning of these laws is going to cause harm to women from many, many aspects. And so this is just taken from ACOG's position. They don't support any restrictions on abortion for any reason, basically. They don't support the government being able to say what we can and can't say to patients, criminalizing or civil charges for having discussions with your patients, referring patients, placing an undue burden on patients seeking termination services. So the right to abortion is very well supported by all of these organizations for very good reason, because we know this is going to harm moms and families, basically. So I just want to point out, so Texas passed a couple of laws last September that have gone into effect, and we're already starting to see some of the downstream effects of what those laws do. So basically, Texas passed a law making termination illegal after 6 weeks gestation, and also put on some civil charges where if anybody even thinks that you talked to somebody about abortion, referred for abortion, drove your partner to have an abortion, you can actually be charged with a civil suit. So it's kind of like a vigilante type situation. And because of that, it's caused a lot of fear among the medical community. And we're already seeing how they've changed their care for women that are going through medical issues. And so just the data that they published within the last couple of months here. So this is data from when the law was passed until now. And they primarily were looking at situations in which this is really going to affect us in the hospital. So I think our laws are mostly going to affect pre-viable membrane rupture, pre-viable preeclampsia, and people that come in bleeding. I think those are going to be the most situations affected, because the reality is we already had a lot of restrictions on pregnancy termination within our states anyway, but these are going to be the situations that are going to be most affected. And so that is exactly what they included in the study. So people that had medical reasons for delivery before viability, which they defined as 22 weeks, before those laws were in place, those patients were offered termination, either via induction or a surgical procedure, or to wait and see, which is called expectant management. And saying you're going to wait and see and do expectant management comes with risk. While you're waiting, mom can get infected, the baby can die. Sometimes those maternal infections can lead to very, very serious sickness, sepsis, being intubated, being on pressor medications, losing their uterus, and even death. So it's not without risk to mom to say, we're just going to wait and see what happens. And so patients should have the opportunity to say, you know what, I don't want to take that risk. I want to make sure I can have kids in the future. I want to be here for my kids and my family and, my life that I have right now. And so that's the standard of care and what's recommended. With this law passing, they weren't allowed to do that anymore without transferring people out of state. So basically, they told everyone, we have to manage you expectantly, wait and see what happens, unless there's an immediate threat to maternal life. And how you define that is very vague, because at what point is it an imminent threat to life? And so there created a lot of confusion and uncertainty at what point they can intervene without having to face criminal charges. And so they looked at things like how many of those fetuses and babies survived, and then what happened to the moms. And so they had 28 cases, all but one of those babies died either before delivery or after. So this wait and see approach did nothing to save any babies. So the outcome that they're, saying that they're trying to get with this is not a reality. There was a big range of delay in care, but the average was 9. I think the longest was like 100 and some days, but the average delay in care was 9 days. And a lot more moms got really, really sick. So literature that had been recently published on how we like standard management, what the complication rate should be, would be less than 30% if you immediately intervened, as we have been. But these moms had almost double the rate of complications, and some of them were very, very seriously ill. So they included things like infection, placental abruption, needing blood transfusion, and getting readmitted to the hospital. 30% of these moms had very serious complications. So not just simple infections that were treated, but they were admitted to the ICU. They ended up having surgical D&C to remove placental products and getting readmitted to the hospital. And one of them actually required a hysterectomy. So it's not good for maternal health to place restrictions on this that put doubt in the mind of the doctors that are trying to, do the right thing. So North Dakota laws on abortion. So currently, and these are kind of backwards. So our current law is called the North Dakota Abortion Control Act. And I just want to kind of point out some discrepancies in the law we currently have and what the trigger law will be when it goes into effect. So I'm assuming everybody has heard that that's currently on hold. It was supposed to go into effect July 28th. A judge put a hold on it basically because they're saying the Attorney General didn't properly certify the law. But I suspect within a month or two, it'll likely go into effect. So the problem is the way abortion currently is defined versus how it will be defined is vastly different. So currently, they specifically state abortion means terminating an intrauterine pregnancy and provides exceptions for saving the life or preserving the health of the unborn child. So that means delivering preterm, knowing that you're going to try to quote unquote save the baby, treating for a miscarriage, and treating for ectopic pregnancies. So there's explicit restrictions currently on the law that provide these exceptions. The trigger law doesn't do any of that. So it defines abortion as terminating a clinically recognized pregnancy. It doesn't say anything about it being in the uterus. So that puts doubt on the mind of caring for ectopic pregnancies. And there aren't really exceptions. So the media has kind of spun this a little bit to say that there's exceptions. There actually is not exceptions. What this law means, so when it says that it's an affirmative defense, that means that if you are accused of performing an abortion, that means you are guilty of performing that abortion. You can then go to court to try to justify why you did it. So basically, instead of how most laws are in the US where it says you're innocent till guilty, this is the exact opposite. You are guilty, you have committed this procedure, delivery, whatever, however you want to call it. And now you have to come and try to prove, see if it's justified why you did it, which is scary. So just to make that clear, these are not exceptions. You have to go and get a jury to basically agree with you that what you did was justified. So the potential justifications would be rape or incest, and then to prevent the death of the female. So what does it mean to prevent the death? At what point can we intervene to prevent somebody's death? Do they have to be a little sick? Do they have to be a lot sick? Does it mean they're going to get sick 6 months from now? Like what does that mean? And so that puts a lot of uncertainty on those of us that are trying to provide standard of care to our patients. Currently, like I said, there's tons of restrictions already in the state of North Dakota. There's 24-hour waiting periods. You have to have a mandatory ultrasound. The person performing the abortion must notify the woman that they're terminating the life of a whole separate, unique, living human being. And so basically all of this is to try to change their mind. That's the intent of these laws. There's also inclusion of inaccurate information. So our law currently states that a woman has to be told that you can possibly reverse the effects of abortion, which is completely not true. There's no medical evidence for that, yet it's in the law. You can't terminate currently if there's a known or suspected fetal genetic condition. So already are families that are going through a serious prenatal diagnosis have to leave the state if they choose to terminate. So that won't change. Prevents how they word it as human dismemberment abortion, which means a D&E procedure. So that's already illegal within the state. You can't provide telemedicine to provide abortion services, and public funding only for to protect life endangerment. So how does the trigger law change management? Kind of like I said, I think the things that are most affected are going to be these kind of pre-viable situations that moms come in with their water broken, preeclampsia, bleeding. There will be other circumstances, but I think those are going to be kind of the biggest three issues that we're going to have to face. So if somebody comes in now, once the trigger law goes into effect, let's say somebody comes in at 20 weeks, her water has broken and she's showing signs of infection, it is up for debate whether we can deliver her within the state. And ultimately it's going to be on the doctor that makes a decision. You know, a lot of facilities are, coming up with ethics committees and things like that, which is all well and good, but ultimately it's the doctor that's performing it that's on the line. And so, your facility can say, we're going to support you in all of this, but at the end of the day, it's not them that has to go to court. So it's really not a good situation. And then, like I said, people facing fetal anomalies or that, have higher order multiple pregnancies like quintuplets, that type of a thing, already have to go out of state. So this is not going to change any of that because it's already restricted. And then longstanding health conditions. So let's say you have a mom that has heart failure or pulmonary hypertension or bad kidney disease. Currently, right now, like if we have women with those situations, they have to get referred to the Red River Women's Clinic. And once the trigger law goes into effect, those will also have to go out of state. There won't be an option within state. So that is the end of what I had for this talk. South Dakota's law is similar but worse because there's also verbiage in there about procuring abortion, which could be construed as like if you're providing information. I don't know if anyone on South Dakota is on the line that has dug it this much that wants to pipe in.
Yeah, this is Katie from the South Dakota side. I still think that we're learning a lot about this. We had met a couple of weeks ago with our legal team because, as you stated, there's kind of some gray areas in terms of what we can and can't do. So kind of hard to elaborate as we're still learning. But yes, definitely very challenging for our patients. And I think we will see the impact of this moving forward.
Awesome. Thank you so much.
Otherwise, that's all I had.
Okay, perfect. Thank you so much, Dr. Tobias. I really appreciate you coming in last minute and already having a great presentation and some good information for us. So thank you. Next, we are going to hear from Dr. Van Eerden. He is a maternal fetal medicine physician at Sanford Health in Fargo. He's worked at Sanford Health in Fargo for 9 years. Prior to that, he was at Sanford Sioux Falls for 7 years. His medical training was in Philadelphia, where he completed his OBGYN residency, and he completed his MFM fellowship in New York City, where he also completed a master's in biostatistics and clinical research methods. He's been actively involved in the development of the PQC and the leadership team. So if you want to share your screen, yep. Perfect.
Good morning, everybody. Thank you. Let's see. Can you see this? Can you guys see that? Are you seeing the talk, or are you seeing my talk with the extra slides?
No, I'm just seeing the slides.
Okay, great. So what I wanted to talk about basically was just a review on hypertensive disorders in pregnancy. I have a ton of slides, and Morgan said that was okay. There was plenty of time, but I still am going to kind of go through this fairly swiftly because a lot of this should be somewhat of a review, but it's also intended to be a review because it's important. and continue to raise awareness. Can you see the second slide there appropriately? Great. So I was going to talk about just general review of hypertension and pregnancy, but with a little bit of a focus on postpartum, since that's what our initiative was about. A review on low-dose aspirin, which was already covered previously. A trial involving chronic hypertension in pregnancy called the CHAP trial, if you've heard about it. I'll talk about that. A little bit of an update in the California Quality Collaborative's hypertension updates, and then some other recent reviews. So in general, hypertensive disorders complicate approximately 10 to 20% of pregnancies. And again, with the focus on postpartum hypertension, that can occur either without having an antecedent history of antepartum hypertension, or it can occur de novo and it just happens without having any hypertensive disorder pregnancy, preeclampsia, gestational hypertension, HELLP syndrome, while the patient was pregnant, which is again why it's so important to focus on postpartum. And it does contribute to maternal morbidity and mortality. Some people look at dividing this into immediate, which is the first 48 hours of after delivery, versus delayed onset, which is 48 hours to 6 weeks. The immediate, hopefully, will be recognized because those patients are going to be in the hospital when it happens. But the real issue is the patients that get discharged and then have issues going on after they're discharged. And then the idea here is that we educate and identify that and take care of it. We don't have a lot of really good data on postpartum hypertension definitions, incidents, things like that, but what I found was about between 0.3 to 27.5%, which is a wide range. So, but it definitely does happen. And again, mild disease may go unnoticed, and that's because of people might be ignoring it, not realize they're pregnant. Patients don't realize, providers don't realize. And again, that's why we were focusing on this particular initiative in the postpartum period. And again, there could be some less familiarity in urgent care centers, emergency rooms, etc. So this article, I kind of use this article as a template to kind of talk about this, this expert review in postpartum preeclampsia and eclampsia. Basically, like ACOG, the Royal College, the Canadian College do not have really clear-cut definitions for diagnosis and management, specifically of new onset postpartum hypertension. We also don't completely understand the pathophysiology of it, or at least the underlying biology of it, if it's a distinct entity from preeclampsia that occurs antepartum, or if it's a completely different entity. And so in part of the evaluation, which I'm going to show you on the next page, the recommendation is to still check the protein in the urine, but we've kind of all learned, I hope, that the protein in the urine really isn't terribly helpful in terms of management of these patients. So this is kind of the framework that they had suggested. You have new onset postpartum hypertension, which is defined at systolic 140 or diastolic 90 or greater. And you can divide this into, if it's just hypertension but nothing else, postpartum hypertension. But if you have protein, cardiac failure, neurologic symptoms, laboratory abnormalities, liver function test abnormalities, renal abnormalities, then this would be considered postpartum preeclampsia or eclampsia, obviously, if there's a seizure. And this is just a proposed framework. Risk factors, and again, this is specifically for postpartum. I mean, these kind of do apply for antepartum, but maternal age, so advanced maternal age, Black race, maternal obesity, having a cesarean delivery, use of intravenous fluids. I think a lot of pregnant women, we think they're young and healthy and they have good hearts and they get a lot of IV fluids, but sometimes that can put them into fluid overload states, particularly when preeclampsia is kind of a state of depleted intravalvular volume. Having a hypertensive disorder in a prior pregnancy, and interestingly enough, postpartum hypertension, at least what I saw, does not seem to be more common among first pregnancies compared to follow-up pregnancies. 60% of new onset postpartum hypertension that occurs in the delayed period do not have an antecedent history of any form of hypertensive disorder or pregnancy. This little diagram kind of shows you some of these risk factors that I mentioned here, and then talks about how they might present and how these patients might present to the emergency department, to the clinic, to the urgent care center, wherever it is that they're going. I would say the majority of them are going to come in with headache, neurologic symptoms. There will be some that the presentation will be eclampsia. Obviously, that's something we would want to prevent. We would want to identify it before that happens, but that could happen. Symptoms of volume overload, shortness of breath, chest pain, peripheral edema, and then the patient might be monitoring their blood pressure at home. They might come into the clinic for a blood pressure check, and it might be elevated, and then that should prompt them to get evaluation. Evaluation, again, not getting into too detailed about it, obviously history and physical, assessing their volume status, making sure they're not having any neurologic or cardiopulmonary issues, checking like a CBC, a CMP to check kidney function, liver function, platelet. Again, the urine protein is a little bit of semantics, but you know, if you have somebody with no history of anything, they show up 3 weeks postpartum, they have a headache, their blood pressure is 150 over 100, you know, whether or not they have protein really shouldn't make a difference, but certainly if there's significant amount of protein, that's going to at least make people who are comfortable in using that protein say, oh, this is probably preeclampsia, but they need to check it. Not everybody necessarily needs to be imaged. Certainly if there's significant neurologic symptoms, then they should be, and that's going to be a clinical judgment to make sure that there's no evidence of cerebral sinus thrombosis or any other intracranial abnormalities. If they have volume overload, you may want to evaluate for heart failure. There's a lot of overlap between peripartum or postpartum cardiomyopathy and preeclampsia. A lot of these patients might look like that, but might not actually have that, or it might have been the preeclampsia that presented with cardiomyopathy. And then, there's some old literature and a lot of old practice for doing a D&C to remove any excessive products of conception, because we believe the underlying pathophysiology of preeclampsia may have to do with some retained placental tissue. And, I don't think it needs to be standard of care to just take these patients for D&C, but certainly evaluating them and making sure that there's no evidence of retained tissue. Again, we need to also sort of keep preeclampsia, hypertensive disorders of pregnancy at top of the list, but we need to think of other reasons why these patients might be presenting the way they are. Management, again, the most important thing is going to be the acute treatment of severe range blood pressures. So if you've got blood pressure 160 systolic, 110 or 110 diastolic, should be treated within 30 to 60 minutes. And in the postpartum period, and we'll get to this with the CHAP trial, but sometimes we don't use certain medications while they're pregnant for concern of effect on the baby. In the postpartum period, I think we can be potentially be even a little bit more aggressive about blood pressure control, because now we don't need to take the fetus into consideration. Magnesium is also very important. Again, this is part of our initiative is the treatment for the hypertension and the magnesium for seizure prophylaxis. Now, again, sort of long-term after the patient gets admitted and evaluated, or if the patient's still in the hospital after having their baby, there has historically been some controversy over the use of diuretics in pregnancy and even in the postpartum period. Again, preeclampsia can be a time when there's intravascular volume depletion. So you start giving them diuretics because you think you're going to just kind of get rid of their edema. That may not work. So if you do identify that they are volume overloaded and maybe they have hypertension, preeclampsia, significant edema, you can certainly, it can be done, but it needs to be done with caution, I would say. And then once this patient is taken care of, as we've pointed out as well, home blood pressure monitoring is important too. Going back to the pathophysiology of postpartum preeclampsia versus antepartum preeclampsia, again, we still don't 100% know whether this is just a subtype of antepartum preeclampsia or if it's a completely different disease entity or if there's just overlap. Again, not to get into the details here, but there are similar imbalances between this soluble FMS-like tyrosine kinase and pro-angiogenic placental-derived growth factor in both entities. With regard to the immune system, antepartum preeclampsia patients have elevated T lymphocytes, but in the postpartum period, they may also have elevations in the natural killer and natural killer T cells, which are not seen in the antepartum period. And there's similar rates on placental pathology of decidual vascular malperfusion identified on histopathology. So that just speaks a little bit to that we don't understand it, and there could be some differences between it. It still contributes to maternal morbidity, and in fact, there may be higher maternal morbidity associated with postpartum preeclampsia, and again, as well as readmission rates and things like that. And again, that might have to do with identification, management, treatment, keeping it on the top of your differential diagnosis list, and just education of providers that aren't as comfortable with taking care of pregnant people, which again is what this initiative was about. So again, importance of patient education, importance of provider education, and then it's also important to talk to these patients about long-term cardiovascular morbidity. There's a lot of information coming out. I'll kind of briefly touch on that later about long-term cardiovascular risk, chronic hypertension, and patients who do have hypertensive disorders of pregnancy. And I think it's going to be important to start getting these patients into their primary care provider, even cardiology, and working with cardiology, and coming up with close follow-up for these patients rather than just like, see you at your next pregnancy or whatever it is. The Society of Maternal Fetal Medicine has put out this handy tool or checklist for postpartum discharge, which you can certainly integrate into your medical record system or into your process at your hospital for discharging patients with hypertensive disorders of pregnancy. And I'm not going to go through the individual things, but it's divided into patient education, making sure that that's occurred, making sure that appropriate follow-up has been arranged. How are we going to be doing blood pressure monitoring at home or remotely? And how are we going to schedule the office visit? We can't be kind of like, well, you delivered on Friday, or you delivered on Thursday, so it's the weekend, so we can't see you. We need to figure out a 24/7, or as a hospital system, need to figure out a 24/7 process for managing these patients, and whatever that process may be. There's also been proposal for using a quality metric for timely follow-up of postpartum hypertension in looking at how you're doing with managing these patients. It's not currently like a requirement for any major organization, but it is something that's at this time recommended. I am going to, well, we can go through this. So again, looking at education requiring the ACOG recommendations, we should be educating physicians, family practice physicians, OB physicians, midwife staff, inpatient and outpatient nursing and clerical staff. So everybody who's going to have contact with these patients should have just a general awareness of like why we're doing what we're doing. Warning symptoms for the patient that would have them seek attention, standardized patient education tools, whether that's handouts or education or something in the medical record system that you're going to give to the patient and their family. It's important for the family to be educated as well, because they might be the ones that identify that something's wrong. And then being able to get devices for blood pressure monitoring at home, having a process in place for that. Again, development, you could be using text messaging or automated systems for reminders for blood pressure checks, reminders for this blood pressure is too high or low, and you need to come in and get evaluated. And again, like I mentioned before, standard process for scheduling follow-up postpartum appointments, regardless of when they delivered, 24/7, and a follow-up blood pressure program. This kind of leads into just a brief review on low-dose aspirin. I forget if it was Dr. Lissard or Dr. Tobias who did this last time or the time before, but this is from JAMA. They actually kind of updated it from what ACOG says to include in vitro fertilization as one of the medium risk factors for low-dose aspirin for preeclampsia prevention. I think it's important to start talking about this with patients. Obviously, if it's their first pregnancy, it's going to be in their first pregnancy. If you're seeing them preconception, which is even more important, to start talking to them about it, because oftentimes there's a lot of questions regarding aspirin. Is it safe? Can we do that? Is that okay? The bottle says not to take it when you're pregnant. So if you start educating the patients before they become pregnant, that would be great. But so first trimester, but even after they experience preeclampsia or they go home, or they get readmitted, then having that conversation now. Remember, next time you get pregnant, you're going to have to be on low-dose aspirin. And then again, Society of Maternal Fetal Medicine has put out these checklists that you can use, incorporate into your systems, whatever, for the use of low-dose aspirin. So you might give this out at their new OB visits. You might give this out to them at their preconception visit, to kind of determine if this is somebody that might need to be on a low-dose aspirin for their pregnancy for preeclampsia or hypertensive disorder or pregnancy prevention. This is kind of a 180-degree shift. The CHAP trial came out in April, and it's not like a huge game changer or anything, but a little bit. And it was looking at treatment of mild chronic hypertension in pregnancy. So chronic hypertension occurs in about 2% of pregnancies in the United States, again, associated with increased maternal and neonatal and fetal morbidity and mortality. There is clear-cut consensus for treatment of severe chronic hypertension in pregnancy, whether that's outpatient, inpatient, postpartum. Again, there's that if you're 160 systolic or 110 diastolic or higher, obviously that needs to get treated and evaluated, and there's no question about that. There is variation in international guidelines for management of chronic mild preeclampsia. So if you're running 140s, 150s, over 80s to 90s, and you're not on blood pressure medication, but you have a diagnosis of chronic hypertension, or you are on blood pressure medication, again, variation in practice and what's the best practice to do. Historically, ACOG and SMFM have not recommended treatment of mild chronic hypertension in pregnancy. And the reason behind this was, number one, lack of data confirming maternal or perinatal benefit. Number one, and number two, concern that the medication, like I mentioned before, may have an issue or impair fetal growth and cause complications to the baby. So this is kind of a historical context for how we got to that. In the year 2000, there was a meta-analysis that suggested that hypertensive therapy was associated with an twofold increased risk of growth restriction or small for gestational age newborn. In 2015, the international CHIPS trial looked at a primary outcome of pregnancy loss or need for higher level care, and it did not differ between the tightly controlled versus the less tightly controlled patients. And they did see that there was a higher incidence of developing severe preeclampsia, but overall the risk of small for gestational age and need on serious maternal complications didn't differ. 2016 Cochrane review and meta-analysis, treatment of mild chronic hypertension did reduce the incidence of severe hypertension by 50%, but did not reduce the frequency of preeclampsia, preterm birth, IUGR, stillbirth, or any of the outcomes. So the CHAP trial was a multi-center trial in the United States. I think it was 70 centers. The goal of the trial was to evaluate antihypertensive therapy compared with control among pregnant women who had mild chronic hypertension. So that's 140 to 159, over 90 to 109. And then they were also looking at the adverse pregnancy outcomes and fetal growth. 1,200 patients got randomized to active treatment, 1,200 patients got randomized to control. In the active treatment, they received standard first-line antihypertensive medications, kind of at the discretion of the OB provider, labetalol, Procardia, amlodipine, methyldopa. And then in the control group, antihypertensive therapy was withheld until they got to a blood pressure of 160 over 105. The primary outcome, which was a composite of preeclampsia with severe features, medically indicated preterm birth at less than 35 weeks, placental abruption, fetal neonatal death occurred in 30% of the treatment group and 30% of the control group, and that was significantly different. The safety outcome in terms of looking at fetal growth, small for gestational age, did not differ between the groups, so that's a good thing. And then in the individual parameters under the primary outcome, there was preeclampsia with severe features did occur in less in the patients who were actively treated compared to the ones in the control treatment. And active treatment did have reductions in medically indicated preterm birth, incidence of severe hypertension, preeclampsia without severe features, preterm birth less than 37 weeks, low birth weight neonates. So basically, the conclusion was that treatment improved maternal and perinatal outcomes and did not negatively impact fetal growth. And then ACOG and the Society of Maternal Fetal Medicine did put out statements regarding this trial, and it did support starting or increasing doses of medications in patients who have a diagnosis of chronic hypertension in pregnancy to maintain levels less than 140/90. That's during the antepartum period. It doesn't answer questions still about gestational, like new onset preeclampsia, new onset gestational hypertension. I think there's a tendency for people to think that they, in those situations, can start medication, but we still feel like the data on whether that changes outcomes is not there in terms of, again, not chronic hypertensives, the new onset patients. And it can also potentially mask the development of severe features of preeclampsia and prevent us from identifying it, diagnosing it, managing it, admitting the patients, and treating it. That might be a little bit of a controversial area. Other considerations regarding this trial are that the American College of Cardiology and American Heart Association has lowered the threshold for chronic hypertension to 130/80. So really none of our data in pregnancy has the information between 130 to 140 over 80 to 90. So we don't know what to do in those patients. I think certainly, so again, those are just some unknown areas. The California Maternal Quality Care Collaborative, which is the California equivalent of our collaborative, is, probably one of the larger ones in the United States, and a lot of people do follow their guidelines, and they put out some nice guidelines for some of these patient safety bundles that we are looking at. And I just wanted to alert you to the fact that both the hypertensive disorder of pregnancy toolkit, as well as the hemorrhage toolkit, have been updated in the past year, and specifically focusing on the hypertensive one. They've expanded the scope to address all hypertensive disorders of pregnancy. They're in alignment with the ACOG definitions. And they do have a whole section on this borderline hypertension. And I really need to look at that and talk with my colleagues about that, about management of that, because I don't know that we feel comfortable that we're there yet. They talk about low dose aspirin again, and then again, focusing on that long-term follow-up and that importance of risk for cardiovascular disease. These are the slides from the CMQCC, so I'm going to just go through them very quickly. They did have a presentation which you can watch online if you're interested. The bundle that they put together is, I think, 238 pages, so that's a lot to go through. Maybe watching their webinar could be worth your while. And then these are, again, some of the slides from it. But again, we still hear people using these terms, but we don't like them. Toxemia, pregnancy-induced hypertension, atypical preeclampsia, even severe mild preeclampsia. We're supposed to be saying preeclampsia with severe features or preeclampsia without severe features. Again, the 5 key elements for management, we've gone over this, but recognizing and diagnosing, controlling the blood pressure, which is the antihypertensive medication, seizure prevention, which is the magnesium, delivery timing, depending on severe features, without severe features, and then again, the importance of postpartum surveillance. I do want to point out that the Joint Commission has made several elements of the hypertension bundle and the hemorrhage bundle part of the requirements for Joint Commission accreditation. So it's important to keep that in mind in your hospital systems if you're getting accredited. This is again repeats, but importance of treating these severe range blood pressures, whatever the circumstances it is, whether it's chronic hypertension, new onset, gestational, whatever, it needs to be treated. There's a risk of stroke. You can figure out what you think is the diagnosis after the fact later. Patient education, the Preeclampsia Foundation puts out good patient education here. You can go to their website, you can give this out to patients, again, incorporate it into your medical record system. It's good to give it out to patients during their pregnancy, during hospital admission, during postpartum, when they go home. Again, from the CMQCC, I just highlighted their data on hypertensive disorders in pregnancy. And would you look at this, like 8% of this occurs in pregnant patients, but look at all these that are happening, and this is pregnancy-related deaths. Look at what's happening in the postpartum, even in some of these other, cardiovascular disease, sepsis, hemorrhage. Postpartum is a biggie, so we really need to be paying attention to these women, which leads to, I kind of went through that fast. I mean, importance of taking care of, obviously, eclampsia, and recognizing the disorder in the emergency department. Again, educating providers that aren't as comfortable with taking care of pregnant patients, because this is where they're going to be presenting. And then again, the long-term follow-up for cardiovascular disease. I just wanted to point out, I don't know if we talked about this ever here, or showed any of the videos here, but the CDC does have this campaign, the He or Her campaign, because of the higher risk of maternal mortality. And so there really is a lot of advocacy going on, and a lot of attention being focused on this. And I think this is a great campaign. They have a handout with all of these headaches, all of these symptoms, if patients have any of them. We really need to be listening to our patients. Missy's talk this morning was very important. We're taking care of our patients. They're the most important person in this whole clinical situation, so we need to hear what they have to say. There's links to the videos. I don't think we need to watch them, but they have some online. And then again, the CMQCC kind of reviews the low-dose aspirin for preeclampsia prevention. The last portion of this talk is just some of the recent articles that have come out really this year, and I think some of these were in 2001, but actually mostly in 2022. There just seems to be a slew of stuff coming out, and I just really feel like I'm happy to see that there's a lot of awareness being raised on exactly what we're talking about in the United States. The CDC MMWR report in April presented some information on the hypertensive disorders of pregnancy between 2017 and 2019. And, they have hypertensive disorders of pregnancy have increased. And there's another article I'm going to show you with more data. Prevalence of unspecified maternal hypertension remains stable. Prevalence of pregnancy-related hypertension has increased. Chronic hypertension has increased too. So more and more of this is happening. So we're going to see more and more of this as well. So we need to focus more and more on prompt identification, treatment, recognition, and management. Proportion of deaths occurring during delivery among maternal deaths that occurred during hospitalization, 31% had any hypertensive disorder of pregnancy, 24% had pregnancy-associated hypertension documented. In chronic or unspecified maternal hypertension, it was in about 7%. This is important and kind of pertinent to what we like to do in our PQC, and all PQCs are doing. The prevalence of any hypertensive disorder among delivery hospitalizations was higher in older women. So 35 to 44 was 18%, 44 to 45 went up to 31%. Higher in Black, non-Hispanic, American Indian, and Alaska Native individuals when compared to other racial and ethnic groups. Those residing in rural counties and zip codes with the lowest median household level income compared to other counties and zip codes, as well as hospitals in the South and Midwest compared to other regions. So there's definitely a discrepancy there. So their conclusion was that the prevalence of hypertensive disorders of pregnancy increased during the 3-year period with noted racial and ethnic, sociodemographic, and place-based disparities. These disorders and treatment of these disorders are preventable with equitable implementation of public health and clinical strategies. And these includes efforts across the life course for prevention, identification, monitoring, treating, like I've been saying, increase awareness, and implementing quality improvement initiatives like we are doing here. Another article came out in July of 2022, again, looking at trends in hypertensive disorders. They had 122 million deliveries that they included. And we can again see that the rate of hypertensive disorders of pregnancy and chronic hypertension have been increasing over time. And you can just see that from the graph there, specifically looking at hypertensive disorders and then chronic hypertension. Eclampsia, this is great news, has declined over the years. Hopefully that is because of identification, recognition, warning signs, and treating these patients. The American Heart Association put out a statement. I'm mentioning this to you because it's a nice little document that kind of reviews all of this. And they go through the definitions of the hypertensive disorders of pregnancies. They go through some of the risk factors. They present some of the potential pathogenesis of hypertensive disorders of pregnancies. And also making sure that we're thinking about secondary causes of hypertension in women as well. And then, like I mentioned before, there's a whole slew of articles that came out. European Society of Hypertension came out with peripartum management of hypertension paper that was, I think, this year or last year. Literature review on best practice. And then JAMA had a whole series of articles looking at a lot of this long-term risk on cardiovascular and brain function. And so again, I'm happy to see the advocacy. I'm happy to see that this is getting the non-obstetric literature is coming out and people are going to be exposed to this. So that's the end of my talk.
Thank you so much. That was awesome. It's a good review of hypertension and all the treatments. So appreciate your time and putting all that work into this. Do you want to stop sharing? Okay.
Yep.
Perfect. We are going to move into breakout groups in just a second, but before we do that, we've got some exciting news for our PQC that I just want to share with everybody. Get my slides back up here. Okay, so we have our new initiative. Everybody we took a vote and a lot of discussion around it. Along with this new initiative, the NSDPQC and North and South Dakota are officially enrolled in the 2022 fall cohort for AIM. And so we are going to be officially designated AIM states and working closely with AIM to implement their bundles. And along with this, there's a lot of benefits to joining AIM. One of them is funding. We get a small amount of money so we can continue this quality improvement work that we've been doing. They give technical assistance. They have a collaborative learning platform with other states. So we'd be able to, share what we're doing and learn from those in our region. There's a lot of AIM partners that we would also be able to learn from and share information with. There's an AIM data center. So with this new initiative, we'll be having a bit better data collection and aggregate information to give back to you guys. So it's not just going to be reporting if you've seen an increase or decrease. It'll be a little bit more extensive, but we'll get better information out of it to really guide where this quality improvement will take us as we work through it. We've got the patient safety bundles, obviously, that we are planning to implement through this next initiative, which is substance use disorder. So if you go to AIM's website, you can look up, I think it's care for pregnant and postpartum patients with substance use disorder. And this, as we know, substance use in pregnancy is associated with severe outcomes for mothers, fetuses, and infants. And as we were putting together a grant application for the CDC grant, which we still haven't heard anything back yet, but we were looking at a lot of the data that was available from North and South Dakota and the PRAMS data. And North and South Dakota have higher rates of substance use during pregnancy than national samples. According to our PRAMS data, illicit drug use is at 9% of women in North Dakota and 7% of pregnant women in South Dakota. We also saw some disparities, some racial and ethnic disparities, as well as income level disparities. For example, South Dakota, 23% of American Indian women used illicit drugs during pregnancy compared to 3% of white non-Hispanic. North Dakota rates were really similar. Rates also differed by income level. South Dakota women with annual income less than $16,000. 16% of those smoked during pregnancy and 21% used illicit drugs. So we can see that there is some room for improvement, and we looked into screening and treatment, and healthcare providers in North and South Dakota are asking women about substance use, at over 95% asking about smoking and drinking, and over 80% are being asked if they're using illicit drugs. And this is from PRAMS, this is like women reporting on if they were asked this. But from all of that screening and asking, only 1% are being, or less than 1% of women are being referred to a substance use treatment program during their pregnancy. And so this disconnect is really where we want to look into a little bit deeper and kind of start our quality improvement work there. And so we're going to have a 2-year approach to this, and focusing on the maternal and infant dyad. So first year, we're going to focus on our moms, and we're going to look at increasing, first we're going to look at increasing our number of participants. So we are going to be at North Dakota's OBGYN conference, we'll be at South Dakota's perinatal conference, and hopefully we can recruit some more teams to join this quality improvement. Right now, hospitals in North Dakota, they currently cover 78% of the births happening in North Dakota. South Dakota, we're only at 33%, so we need to do a little bit better of work in South Dakota to get some more births covered with our PQC initiatives. But once we get into the substance use disorder initiative, we are going to be looking at increasing the percentage of women with opioid use disorder being referred to medication for OUD, and we'll be disseminating like strategy screening tools and education materials for patients and for our providers. We'll also be looking at increasing percentage for women with substance use disorder who are referred to or received recovery treatment services. And same thing, we're going to be compiling and disseminating a resource map, so it'll be easier for you to see if you have a patient that needs some extra services. We're hoping to provide a comprehensive list of where you can send your patients or refer them. And so we really want you to join us on this next initiative. We'll be starting to put together our teams this fall. So first you need to assemble your team, which is probably already your team that you're working with now. We'll have another statement of intent for this next initiative, and then we'll need to execute some DUAs, and if your hospital requires an IRB process, we'll need to get that started so we can share data a little bit easier. And also with our partnership with UND, this will make everything, I think, a little bit smoother and easier this time around. Now we'll move into our breakout sessions. Let me stop sharing. We've got 2 great sessions. We'll have one with Dr. Van Eerden, and this will be a time where you can have some of your questions about his talk. And then our second breakout session is with Anita Fredericks, who is the president of Tribal Nations Research Group. And so let me hurry and just get these rooms put in. Sorry, it wouldn't let me do it a little bit earlier. So Anita, do you want Molly in there with you? Okay. Sorry, hold on one second. Okay, so you all should be moving to your rooms.